All right. So our first speaker is Jennifer Hopping. Jennifer is a licensed clinical social worker who completed her master's degree at the University of California, Berkeley. She has over 15 years of experience in the hospital and clinical settings and teaches at CSU's Schilly Institute for Palliative Care. Jennifer works as the palliative care manager for Providence, Oregon, and continues to practice clinically in the inpatient and outpatient settings. She also serves as a member of the National Post-Paradigms Research and Quality Committee and the Oregon State Legislature Advanced Directive Adoption Committee. Thank you for joining us.
Great. Thank you, Alice. I appreciate that. Hi, everyone. Very happy to be here. Thank you all for joining us today. It looks like we have about 18 folks on the line, which is great. And I appreciate Alice kind of giving us a once over and letting us know what to expect and how to navigate this time. I admit I've had a little trepidation about doing a virtual talk. I haven't done one before. I much prefer the live in-person environment and completely recognize that right now the virtual format is what makes sense. But to that end, I want to say that if you have a question, especially midway through, because I have a case study I'd like us to kind of chew on together. And if you don't mind just using the raise your hand function, and then when you ask your question, if you wouldn't mind putting yourself on video, that'd be great. And I think it'll create a little bit more of that kind of conference talk feel. If you don't want to be on video, you can just audio, but I'll absolutely accept any questions that come through in the chat and I'll address those. But I would invite you to participate in a little bit more of a didactic way if you feel comfortable or so inclined. Okay. Great. So today we are going to review non-pharmacological symptom management, which, as many of you can imagine, can be a really excellent and helpful intervention in the serious illness population. Kind of a point of preface, I would never kind of expect or suggest that non-pharmacological symptom management replace pharmacological symptom management. I think that there's just something to be said for what we have for pain and shortness of breath or dyspnea and anxiety medications. And I think that when we augment those with non-pharmacological symptom management, that's really when patients experience the most relief. Because certainly anything in the pharmacological realm has its limits as well. And it comes with side effects and the like. And truly with the non-pharmacological symptom management, there's none of that side effect burden, which I think is really compelling and just another reason why we should consider having some of these elements in our toolkit. So before we jump in, I thought it might be helpful to get a sense of kind of who's with us today and where you work. And so I believe Alice so kindly set this up for us in the poll section, which I'm new to. So, and it looks like, yeah, work setting is first. So yeah, great. Thank you all. And then, yeah, the next question is around discipline. So thank you. Great. So looks like we have a lot of clinicians with us and lots of folks in inpatient and outpatient alike. So that's helpful. Thank you. Because there's as you can imagine, there's certain interventions that I think are really well suited to hospital, and others, if you have more of a longitudinal relationship or the opportunity to have that with a patient and a family, I think that kind of tailors what interventions I think I might recommend or utilize. So this is helpful. Looks like most, by a nose, most of you work in the outpatient or clinic setting, but many of you also in inpatient. And looks like we have a lot of social workers and nurses on the call, and one of a more traditional, let's see, yeah, physician, NP or PA. Great. All right. Thank you all. Okay. So to kind of ground us, I thought it would be helpful to kind of outline the population I'm referring to when I say the palliative care population. I really think of that as patients with a serious and life-limiting illness. There may be a place, or I think there is a place for some of these interventions in chronic pain, or especially chronic non-malignant pain, maybe back pain from an injury years ago. But when we talk about who we're taking care of here and who I really tailored this talk to, it's the kind of traditional definition of the palliative care population. So I think most palliative care groups and teams and systems kind of exclude patients with a post-op pain that's seen as acute or chronic non-malignant pain. And so that applies here as well. So the most prevalent symptoms are pain, shortness of breath, or dyspnea, and anxiety. And I spend the most time talking about pain, but certainly I think that these tools can be used for virtually any symptom. So we'll kind of chew on that a little bit more, but that's kind of the general idea, is these three main symptoms. So I thought it might be helpful also to pull together what is kind of the prevalence of pain experienced by various diagnoses that tend to be kind of make up the lion's share of our patient population. So of course, not surprisingly, cancer is probably one of arguably the number one patient population that we serve in palliative care. And you'll notice that a lot of these have pretty big ranges, but I still think it's kind of helpful to get a sense. I would imagine that for cancer, closer to the 94%, especially when cancer hits that advanced stage and stage 4, or just globally the advanced stage of cancer, I think that we can expect pain to really be present. And it's also associated, as you would imagine, when pain increases, it's associated with a poor quality of life, which really impacts mood and overall functional status. So it can be pretty debilitating. And then in terms of kidney failure, this had a pretty big range as well. I think that, again, it depends on where someone's at within their disease trajectory. If somebody has recently started dialysis, they might say that this is higher for them, but then once their body kind of acclimates and comes into a new normal, I'd imagine it's lower. And then, just as kind of they get sicker or more debilitated over time, perhaps they've been on dialysis for 2 years, they're starting to have some more complications, maybe an access infection or low blood pressure, maybe a few bouts in and out of the hospital, I think then pain can increase. And it's also associated significantly with depression, more than other chronic conditions, along with insomnia, irritability, and anxiety. And then for COPD, the interesting thing is, as many of you know, I'm sure, is there can be this persistent kind of discomfort, or it can be episodic, which I think also makes it a little bit tricky to treat, especially just with pharmacology. I think it can be a little cumbersome. And then dementia, I think it's really hard to assess this, though I think if we presume that folks who we're working with dementia have some underlying low-level pain that they're not necessarily able to communicate to us effectively, I think if we presume that or we ask more kind of thoughtful questions, we might be able to make some headway, because there's a lot of data now that shows that folks with dementia who have these kind of spikes in behavioral disturbances may be experiencing pain, and they're not able to, I would say, effectively communicate that, because I think they are communicating it, but perhaps not effectively communicating that. Let's see. I'm just checking the chat really quick. Okay, great. Just want to make sure there wasn't anything urgent or any issues with the PowerPoint or what you all are able to see. Let's see. CHF, and actually at Providence where I work, this is our #1 diagnosis. I believe it's also our #1 diagnosis in hospice, as it is in palliative care. So it is, it's one of those really common yet not fully understood, I think, by the general population. But it comes with a pretty high symptom burden. I mean, there's a lot of fluid retention and labile weight and shortness of breath and fatigue and some discomfort and even pain as well. And then having that kind of undermanaged can really lead to depression and anxiety, especially anxiety around an exacerbation and illness. And then ALS can be episodic or prolonged. I actually think it's both. I think that folks with ALS have both episodic and prolonged pain, which, as we all know, is associated with worsening quality of life and certainly exhaustion. And then lastly, MS, intensely exacerbated by catastrophizing, which, I mean, I can certainly understand. I think a lot of folks who get an MS diagnosis, first of all, they've been probably in and out of the healthcare system quite a bit with kind of mysterious symptoms. It's usually a diagnosis that's made much later after a lot of other rule outs and a lot of diagnostic workup. And then when they hear this diagnosis and it's pretty heavy, and when and where these symptoms might peak or valley is largely unknown, and it's really variable person to person, I think it just breeds anxiety and worry. And then that can lead to catastrophizing, or the patient just feeling like my life essentially is functionally over, and feeling this really large, just my life is now a catastrophe with this really debilitating diagnosis, with a really unexpected and jagged course. So any thoughts on this, or does this seem to kind of resonate with any of you, or anybody want to comment on any of these diagnoses? Oops. All right. I'll wait, and if you have a thought or a comment, then feel free to put up a hand. Otherwise, I'll just keep going. Okay, so unsurprisingly, depression and anxiety are common in patients with advanced illness. And I just kind of wanted to bring awareness to that. I think it's all our anecdotal experience, but when we are able and better kind of equipped or aware to kind of screen for it, I think then we can move the needle a lot more when working with folks with serious illness, and just kind of having some empathy around the fact that when they're struggling with depression and or anxiety on top of their serious illness, they're going to have a greater time coping, or greater difficulty coping and managing their physical symptoms, which is all the more reason why I think non-pharmacological symptom management can be super helpful. So I also just thought we would just take a moment to kind of define pain, which I found really interesting. And I think this definition in particular really resonated with me from the International Association for the Study of Pain, which is they really define it as an emotional experience in addition to a very unpleasant or physically taxing one. So I think a lot of times we are a little binary in our thinking around pain, and we think about the physical experience of it and how difficult that is. But because someone's reaction to pain and experience of pain is so subjective, I think that it's prudent of us to remember that when we're thinking about how to assess for it and treat it. I think it creates kind of a broader understanding, which is super helpful. I think it's great to start with an objective assessment. And I know that we've all seen these 0 to 10, tell me about your pain on a scale from 0 to 10, 0 being no pain and 10 being terrible. And as I was looking for an image, I just found it, I kind of chuckled a bit because there's so many. So I thought I'd share these with you. I mean, wow, this hurts worse. This is really interesting. This one I think is probably the most unhelpful. I think that sure, but mild and moderate, that's not really kind of common parlance for many folks. And this is just not the most helpful. This one I thought was actually interesting. I hadn't seen this before, but I like that it shows kind of the gradations other than just the faces. It actually has these bars here. So I thought that was interesting. So I think it's really good to start with that objective and then just kind of this recognition that symptoms are always multidimensional. They certainly afflict our body and someone's mind and kind of the sense they make of the pain, which is very similar to spirit or the meaning they ascribe to the pain. And we usually have thoughts or emotions and feelings about the pain, worries about it. And it's also influenced by our culture and what kind of our lens through which we see the world and our upbringing, and how that kind of informs and colors our experience of it. I mean, I'm a parent myself, and I've met so many parents who are in different camps, right? Like some who say, like, anytime my kid just has any sort of bothersome symptom, I just want to like help them. I want to alleviate. I want to take it away. I want to just give some Tylenol and get that fever down, even if it's just a little bit, it's just so hard to see them go through that. And then others who say, oh, no, the pain or a fever is the body's kind of warning system. And I want my child to learn how to experience that and understand that it's a warning system and what to do with that. So all of these things in childhood and then early adulthood inform kind of how we approach it later, especially in the context of serious illness. And then there's certainly some socioeconomic elements as well. There's a lot of data that show that folks who are in a minority group, whether people of color or LGBT, there's sometimes just discrepancy in how their pain is assessed and treated. And it seems like healthcare could certainly do a lot better with equity in that regard. So all of these elements really are influencing kind of how we approach it, or they should, I think, how we approach it. When we think about it as far more than the physical experience, we're going to be better at treating it. I really like the ESAS, the Edmonton Symptom Assessment System or Scale. For those of you who aren't familiar with it, I think it's fantastic. I just wanted to put a little plug in it because it goes through symptom by symptom and it'll say pain, tiredness, drowsiness. It defines the difference, nausea, lack of appetite, or good appetite on a scale from 0 to 10, all the way down to depression, anxiety, and whether or not they feel they're having well-being. And I like that it's a 0 to 10 because I found that before I used this, I would ask a patient, are you having any pain? And they would tell me yes or no and where, and okay, and then I'll let your physician know and we'll see what we can do about that from a pharmacological standpoint. And I might say, do you have any other symptoms? I mean, not really, maybe a little fatigue and shortness of breath. Okay. But I find that when I go through item by item, it's far more than the tip of the iceberg. When we take a moment, it truly just takes a moment to ask. So in terms of your appetite, would you rate it as no lack of appetite, so a good appetite as a 0, or would you say you're struggling with appetite? You just feel so crummy, you do not have an appetite. That'd be a 10 of just, I don't want to eat. And when we ask them, I think, first of all, it highlights our specialty as palliative care practitioners, that we care far more about their global well-being and their symptom burden and how they're coping and how they're doing. We care about all of it. We also care about their goals of care and making sure their care is aligned with what's important to them, but we're so much more than that. And when we do a comprehensive assessment, I think it speaks volumes when we do. The other things I like to do is then I get into the subjective, and this is where I really feel the meat is. So I will ask things like, how does the pain affect your everyday life? What does it kind of stop you from doing? Some folks might say, well, gosh, I haven't really been able to grocery shop in a long time. I just get too fatigued and pushing the cart. I just can't do it. I don't really like that. I haven't been able to go fishing. I haven't been able to be with my grandkids like I want to and get down on the floor with them. And I can't do those things. So that's really important information and really great context to have. And then I ask, what makes your pain better or worse? And so sometimes folks just kind of focus on the physical, and they might say, well, anytime I try to get up or walk, anytime I do stairs. Some of them will say, sometimes when I lay flat, but all of this is really great information to have. I ask if their pain ever feels out of control. And almost everyone says yes. And then they describe kind of a state of panic that sets in, understandably so. And then that informs what intervention I might suggest. And then I ask, what are your beliefs and thoughts about pain? I think we've all had encounters where we meet someone who has a very kind of spiritual and existential, but largely a spiritual lens through which they experience their pain. And they might say something like, I kind of just feel like this is my cross to bear in this life. I have this pain for a reason, and I need to experience it. I need to think about it. I need to reflect on it, and I need to handle it with no medications. I just need to be completely aware of it. And that's really interesting. And it's that also would inform kind of how we would approach their symptom management, because medications aren't the only way. They may arguably be the best way, but if someone is just not going to wrap their head around using that, then what else can we do to support them? And how distressing is your pain compared to the other symptoms? Some people say, yeah, I have pain, but what worries me most is the shortness of breath. I hear that the most with respiratory issues, especially COPD. And then lastly, I ask, because this will inform me before I launch into whatever I suggest or offer, which is what strategies, if any, do they have with coping with either kind of chronic persistent pain or a pain flare? And I find it really informative, because some folks might also have kind of a mindfulness practice, or they might use some guided imagery or breathing to kind of calm, and that and maybe they just say, oh, I try to distract myself, and which actually is a coping mechanism. It can work. It just usually doesn't have a long shelf life. It usually can't take the edge off for long, but all of those things are super helpful when you're thinking about this. And any questions pop up, feel free to raise a hand or interject. If any of you use these, or you have a follow-up question about it, or any context or information you want to add, go ahead. So the next, I thought we would talk a little bit about a case study of a woman I met, and obviously this is not her, but nor is it her name, but I thought it would be helpful to just kind of put a lot of these abstract concepts onto somebody that we can just kind of talk about as a group. So Joan was a 51-year-old with pancreatic cancer, and she was a very high-functioning bank executive until she was diagnosed. And when I met her, she came to the ED in a pain crisis and she was doubled over. She was kind of the personification of miserable. So the ED physician placed a palliative care consult, and fortunately at the time we had the bandwidth to come down emergently to the ED, which was really great. And then they started her on a short-acting opiate to kind of take the edge off so that we can actually have a conversation with her where she's not just having this incredibly intense experience where she was, as many of you know, when someone's having that intense of a pain crisis, they're not really present with you. They're just so engrossed in their body because it's just, you know, all these alarms are going off and you can't really have much of a conversation. So that was started, which was really helpful. And then the physician, the palliative care physician, and I went down to the ER to talk with her. She said she finally had her pain down to a 4, which was great. And that, you know, made it so we could have a conversation with her and with her spouse. And then I could tell Joan started to feel a little anxious when she thought about the prospect of going back home, because she said, I don't know what to do if my oral medications don't work. Like I can't do that again. And I could tell her breathing was increasing and she looked like she was on the cusp of a panic attack. So the palliative care physician recommending putting Joan on a long-acting medication so that she hopefully didn't have these major peaks and valleys, that she just kind of had this steady state, and then still had the short-acting opiate for breakthrough as kind of recourse. But otherwise, Joan was just kind of doing this a lot with her short-acting opiates to no fault of her own. That's just kind of how I believe her oncologist had prescribed her pain medicine. I believe it was Ativan lorazepam that was also suggested, and she was open to that, but she still remained visibly worried. So I want to know if any of you want to chime in and just maybe share with the group what your initial thoughts are about Joan. Okay, if there's no one, I'll just keep talking at you, which is totally fine. All right, let me see if there's anything. Oh, yeah. So someone's commenting that it sounds like the palliative care consult came a little late. Agreed. I think Joan would have benefited from concurrent palliative care and oncology care early on. And pancreatic cancer, like advanced or stage 4 lung cancer, are one of the two, I think there's 3 or 4, but they're one of the two diagnoses that actually are recommended for immediate referral to palliative care concurrently with their oncology care, no matter how aggressive the patient and family prefer to be, that it just, the outcomes tend to be so much better. And then I think I saw a hand up. And then Mari, was that you? Let's see.
So sorry, Jen, I clicked accidentally.
Oh, no worries. Thanks. Okay. All good. Okay.
There's a comment from Carrie. Sometimes
There
a
we
pain
go.
crisis is an indication that cancer has advanced. And I wonder if this is on Joan's mind and an additional source of anxiety for her.
Thanks, Carrie. I absolutely agree. I think that is absolutely what was happening for Joan. I think that in that moment, she may have felt that her anxiety and her pain were equally as problematic, and she was experiencing them equally as intensely. And I think that that was the underlying worry. So that's a great call out there. Yeah, so one of the things that really stood out to me was Joan's anxiety and just how much it exacerbated her physical pain. And it just made her physical experience so much more intense. And when I noticed this happening the most in the inpatient setting is that when they're, but this can happen in the home setting for hospice or home health, more often hospice. But I would say in the home setting and then in the inpatient setting, when a patient's experiencing a pain crisis and they're waiting for help, especially if they're in the hospital, they hit the call light and they're waiting. And so they don't know if the RN will come in 1 minute, 5 minutes, or 10 minutes. And that lack of knowing is what really increases the anxiety and the experience of the pain. And so knowing that, what I find is once the patient's pain is controlled, like once Joan was able to function again, or at least have a conversation at her pain being at a 4 out of 10, what I like to do is I really recommend in providing some psychoeducation about what we're observing and what we think is happening. So I let Joan know that it seems like when she's in a pain crisis, her anxiety takes over because she's not sure when she can get relief or if she'll get relief. And everything worsens, her breathing, the way she's holding herself, everything tightens. And I let folks know that when we are anxious, our mind is actually not as present as we think it is. It is catapulted into the future. Because the definition of anxiety really is a worry about a future state, whether that future state is the next hour, the next day, or the next year. We are not present. We're worried about what if this pain continues? What if the nurse takes an hour to come? What if the pain medicine, once it gets started, doesn't work? What if? And we're not here. So letting them know that one of the best antidotes to that is presence, no matter how unpleasant the present currently is. If they're able to come back to it and shift their thinking or just kind of what they're preoccupied about, it can be incredibly helpful. And again, this is to augment pharmacology, not instead of. It's to be used in addition to. So knowing that help will be on the way, or that help is on the way, that they are due for another breakthrough medication. But that right now they are alive and they are having an incredibly difficult time, but they're here, they're okay, they're going to be okay. So a lot of times when somebody is in a pain crisis, they kind of develop that tunnel vision. It's all they can see, it's all they can think about, it's all they can experience. So I touched on that, but when we root ourselves, when we encourage them to root themselves back into the present moment, it can really anchor them and help them start to come out on the other side of the panic attack or the anxious episode. So how might we do that? As many of you are probably familiar with, or maybe have your own practice, mindfulness is sincerely, I think, the best strategy or tool to kind of offset that anxious experience and help folks come back to the present moment. So, and I just like to make sure we have a shared understanding, though I'm sure none of this is new to any of you, but kind of the basic tenets of mindfulness are being fully present and accepting things as they are, simply because they are. I mean, it is what it is. And when we have less of a fight around that, then it tends to kind of soften and disarm us. It also increases our awareness of unpleasant emotions. Mindfulness really encourages us to just take notice. I'm feeling anxious. I'm feeling worried. I'm having a lot of pain, and I think the pain is spreading. It helps us really increases our awareness of what's happening within us. And then we can be more informed as we respond to it. And I think most importantly, it encourages and cultivates self-compassion, because the idea is to have kind of a non-judgmental awareness about whatever you're experiencing and being very neutral about whatever you're experiencing, which also can make tough emotions a little bit less icky. And I feel like when I give those tough emotions a little bit of airtime, even just internally, they tend to dissipate a little bit sooner. It's definitely, mindfulness is a practice, and it is kind of a way of being and navigating the world. And I think that folks who practice palliative care are well suited to take up a mindfulness practice. I also find it easier to teach patients when it's a practice of our own. And I think you can, kind of make more of a compelling case about its value. But what I found, unsurprisingly, but just really great that there's already a lot more data within the last 10 years on this, is that when patients practice mindfulness, that we actually see a measurable improvement in emotional regulation and the strategies that they employ to kind of manage physical illness. And they tend to ruminate on the past less, and they worry about the future less because they are so present. And then most interestingly to me, it helps folks engage in less avoidance of difficult feelings and situations. So perhaps a patient who's instructed about the value of mindfulness in their practice and in their coping early on in their cancer trajectory, perhaps by the time they become an inpatient with an exacerbation in their illness, and they have to have one of those uncomfortable family meetings with the palliative care team, perhaps they'll be a little bit more emotionally prepared for that. So any thoughts on that or comments?
I have a comment. My name's Carolyn, and I've tried this a lot in my practice with patients and families, and I do encounter some challenges, especially for folks who have kind of made their mind up that doesn't work for them, or breathing techniques don't work for me, or folks who are so anxious and so avoidant that they kind of need more of the distress tolerance stuff first. And I'm still trying to learn ways of introducing this and practicing with patients who aren't very psychologically minded. Because I sometimes go too far in the explaining and the non-judgmental. I mean, you just did this in a beautiful way, but lately I'm just leaning to let's just do it. But I'm just curious, from your practice, what have you found to be successful in terms of working with patients who either aren't very psychologically minded, or kind of avoidant, or kind of not interested in these types of things?
Yeah, that's a great question. And certainly there are many folks who it just doesn't seem either to resonate with them, or something that, to your point, they feel kind of equipped to try, or perhaps they tried some version of it a few years ago or recently and it just didn't seem to be a fit. I think that can happen. The times that I notice it being the most successful is after a pain crisis. So I feel like when I am doing palliative care upstream for, let's say, a new pancreatic cancer diagnosis that was given that concurrent referral to palliative care, and they met me as a palliative care social worker in a clinic, I would say about 50-50 were patients open to a mindfulness kind of technique or learning more about it. And then the other 50% were like, no, thank you. Nice to know that I could ask you if I want. But after a pain crisis, I found them to be the most ripe for hearing about something new. The other thing I do is I really like the idea of giving people permission. And it may sound like a small thing, or it may sound like, oh, sure, we do that in the hospital to build rapport. Yes, and I find that when we increase their agency, or they're feeling like they're choosing to hear about something, another intervention or another way to approach something, or another insight, they tend to almost emotionally or internally ready themselves for it. So for example, with Joan, after she heard about the pharmacological interventions that were going to happen and what we were going to change, I said, you know, Joan, what stands out to me is this profound experience of anxiety that you have. I can only imagine that it's really awful. And I wonder if you might be open to hearing about some other techniques that could complement these changes in your pain medicine and your anxiety repertoire. I'm just like, what do you think? Oh, yeah, I'd be willing to try anything. And I don't know what Joan would have said had I met her in month 1 when she was about to start chemotherapy. I mean, she was a high-level executive. I think she read a lot of books. I think she listened to podcasts. I think she probably would have been in that 50% to be so inclined, but I don't know for certain. But I will say, even if somebody declines it and they're kind of not in a crisis, I can't help but think you might have an organic opportunity to try again after things get super hard when just using medications. And certainly not everyone, and certainly there are plenty of folks who, like, hospice isn't for everyone, mindfulness isn't for everyone, but I hope that more folks might be inclined to give it a try after a tough time. But if anyone else has any thoughts or approaches that are helpful, feel free to please put them in the chat, and then others can look at those as well. One of the things that I found incredibly helpful for people who are super interested in mindfulness and in trying to learn more about it and incorporate it into their practice, I would imagine this for somebody who is more upstream in early diagnosis with concurrent palliative care, or it could be, it doesn't have to be oncology, CHF, or the like, but John Kabat-Zinn, as many of you might know, started the mindfulness-based stress reduction, MBSR, at the University of Massachusetts. And all of his referrals initially were from the medical center, and they were people who just had these refractory symptoms, whether it be chronic back pain or just shortness of breath and anxiety from CHF or COPD. And he just made incredible advances and gains with them along the way. So just something to think about. But the best part about this is the course is now offered virtually for free, which I believe is new due to COVID. Before, you had to kind of attend a seminar, and it was once a week. But with COVID, they've really changed things, and it's a fantastic resource. I would say that this technique, though, might be my number one go-to, and the one that I find incredibly helpful. Some people call it the 5-4-3-2-1 coping technique. It's also known as the grounding exercise. And I instruct patients in the hospital to do this when they are awaiting. They hit their call light and they're waiting for more pain medication, and they're not sure how long they're going to have to wait. Or perhaps their spouse just called hospice emergency line and they're waiting to see what to do next because their pain is spiking up so much. I find this to be incredibly helpful. It also works with children, teenagers, because it is a very simple yet sophisticated way to get the mind back into the present moment and out of that anxious state. So what you ask them to do is look around the room in the middle of the panic attack and name 5 things that they can see. And then 4 things that they can touch. And even in a hospital bed, the sheet and the bedside table and maybe the call light, and to listen for 3 things you can hear. And even if a room is quiet and you're listening attentively for sounds, you will pick up probably easily 5 or 6. And then 2 things you can smell and 1 thing you can taste, whether it's a glass of water and then they take a sip of water. Maybe they smell the sheets, or maybe they smell their shirt or just their hand. anything, but I find that by the time I get to 3 and they're looking around for 3 things they can hear, visibly you see the difference. It's kind of incredible, actually. And so what I like to do is instruct the patient about this kind of with, as I mentioned, with their permission. And I also instruct their primary caregiver, because sometimes the patient's in such a crisis state that they need their caregiver, their spouse, or their adult children to say, oh, hey, let's do this. Let's look around the room right now for 5 things that you can see and just say them out loud to me. And it's incredibly powerful. And I like it a lot. And a lot of patients have given me kind of the anecdotal feedback that this was something that felt simple, easy to remember. Because if they did 3 things they could see and 4 things, they could smell or what have you, it doesn't really matter. It's just, the idea is to really activate all of their senses to bring them back to the present. The last technique I wanted to review with you all is a lot of folks really like the idea of guided imagery, and I do as well. But there's one piece of that in particular that I find the most helpful with patients experiencing a high symptom burden. So the basic tenet of guided imagery is to kind of close your eyes and imagine a more peaceful situation, and one that you feel the patient feels relaxed in. It could be a beach, it could be a beautiful wooded scene, bunch of trees and fresh air and all the like. But actually, a colleague of mine taught me this one, which is, it kind of just builds on this idea of building more awareness within the patient about the anxiety experience. And it says, when you are feeling incredibly anxious, imagine yourself on a very busy train platform, and your thoughts about the future or the next hour, the next few minutes, or tomorrow are whizzing by you like Tokyo or Grand Central Station. And without you even realizing it, somehow you got on that train, and you have the ability at any moment, because of mindfulness, to recognize you got on, without your awareness, onto a very busy moving train, and that you are going to take a moment and step back onto the platform. You might still see the trains going by, but you're not jumping on those trains. You're not letting your mind be carried away by the thoughts. You're instead recognizing them, giving them a little airtime, but noting them and letting them go by. So this one also, I think, can be incredibly helpful, especially, again, as someone's waiting for the pain medicine to take effect or waiting for someone to come to their rescue. So I wanted to just finish up with Joan. So I made the observation that she still seemed very, very worried. And she noted that she had felt increasingly anxious about pain control as her cancer progressed. I think she was also having some existential distress, as one of you noted earlier. I think it was Carrie. And so I offered to provide her with some more information about anxiety and kind of how it shows up in serious illness. And she was a sponge. She was just really, she had tried to wrap her head around this. And I think for somebody who is such rooted in numbers and accounting in her life, I think that this kind of somatic experience was really foreign to her. And but she was really open to kind of hearing more about it. And then I gave her some choices of, here's some different mindfulness techniques. They've all been shown to be helpful for your situation. I'd really recommend this one called the 5-4-3-2-1 grounding exercise. And she said, sure, I'm willing to try anything. And her spouse really took to it as well, because I think he felt like he wanted to be able to do something, to have something concrete to help his, his desperate spouse when she was having these crises. And then at the end of our talk, she with the palliative care physician, when we came back, she asked a lot of really poignant questions about her prognosis. And then once she learned that her prognosis was weeks, she opted to go home with hospice, which was the best thing for her. And she had exquisite pain management. I had asked her, I saw her for a couple days, 2 more times after our initial meeting and before she went home. And I had encouraged her to try the exercise while in the hospital. And I think that if you work in the hospital or the clinic and you ask them to do it at least once with you, the chances of them using it at home, I think, are far increased. So I would encourage that. And I just thought I'd throw this question out there, just in terms of if you had more time with Joan, would that kind of affect your interaction? I would hope that it would, and how you would tailor your intervention. If I had met her earlier, I think I would recommend, and if she was amenable to it, I would recommend the MBSR John Kabat-Zinn program, or at least to kind of expose her to it and give her some literature on it and see if she was interested in that. I think she could have had a less complicated course had she had more tools in her toolkit. I also think it just would have been so much better had she gotten that long-acting pain medication to supplement the short-acting earlier on. But sometimes, you know, one of the things we certainly cannot control is when folks are referred to us. We kind of have to work with what we have as best we can. So I'm going to catch up real quick to the questions here in the chat. Yep, personal practice. Great, okay, all right. All right, and I thought I would just take a moment really quick to just give you all some context for how prevalent this really pesky notion of suffering and how it can manifest in patients, especially with advanced cancer versus ones who don't. Just something to think about, and there's ways to kind of screen for it and assess that, but we certainly don't have time to in this talk to get to that today, but I just thought I would share this with you all because I think when we're a little bit more aware of it, we might just have a little bit more of an eye for it. And I think we would all probably say that Joan's experience was certainly at that level. It wasn't just kind of a physical experience. It was just this kind of whole person experience that really caused a lot of burden. Interestingly, and not unsurprisingly, patients who request aid in dying, 91% have endorsed some amount of suffering. So when we do a really good job of symptom management, especially attending to pain and anxiety, I think we might be able to increase that 9%. So something that I wanted to share with you all. Then I had a couple other slides in case we had time, but since we don't, I'm going to come forward to my last slide. Just to wrap up and encourage you all to continue to think about pain as pain management as a multifaceted kind of approach, and to practice it in a more kind of complex, comprehensive, I should say, way. And certainly lean on psychoeducation, offer to teach patients a little bit more about what they're experiencing, what you're observing. When you ask their permission, you're giving them agency, and you also increase your rapport, certainly, but you also just communicate empathy and that you care, and that you want to try to give them insight to what they're experiencing. As a lot of patients, this is just not, essentially almost all patients are lay people unless they've worked in healthcare. And of course, this non-pharmacological symptom management complements medications that are incredibly useful and essential in many of our patients. And then if you have the opportunity to see folks over time, I would continue to assess them each time you see them, whether it's through an ESAS or just with those kind of subjective questions, and see what's helping, what's not, what can you turn the volume up on, and what. And it also just, it's a great feedback loop for you for what techniques you've employed that seem to really be moving the needle for them. I think it's just great all around. Okay. Thank you, everyone. I really appreciate your time and attending, and thank you very much. I will check the chat for any last questions.
Thank you so much, Jen, for that excellent
For sure.
talk. And I'm going to take just a minute while our next speaker gets ready and settled in to get quick feedback from you all. We are currently planning for the 2022 Pacific Northwest Palliative Care Conference, and we really hope to be able to have that in person, and want to understand if you might be comfortable attending in person. It is slated for April of 2022. If you have responded to this already, feel free to not respond here, but if you haven't, please let me know what you think. Okay, I will give it another 5 seconds or so. And thank you so much for your feedback. All righty. And I'm just going to introduce the next speaker real quick. Oh, share slides. Okay. Our next speaker is Yi Yan from the University of Washington. Yi Yan is currently a clinical nurse educator at Harborview Medical Center. She has over 20 years of experience in critical care nursing, and has had many different roles, including ICU staff RN, care coordinator, clinical nurse educator, nursing faculty, and researcher. Yi's clinical expertise lies in cardiac devices, and her research focuses on chronic comorbidities, geriatric, and palliative care nursing. Welcome, Yi. And you are welcome to share your slides.
Yeah, thank you, Jen. Thank you, Alice. I'm trying to, but it's still not allowing me.
Oh. I have made you host, so I'm hoping that trumps everything. Do you see the little green share button at the bottom of your Zoom screen?
Yes.
Okay. And
it only gave me 2 options of one participant can share at a time or multiple people can share. Okay, now it works.
oh, good.
All right, thank you.
Mm-hmm.
So are you able to see my slides?
Mm-hmm. Yep, I can see them.
All right. So thank you for Jen for that wonderful presentation earlier. And I also want to thank everybody who came here. Today is a very hot day, so very happy you can be here with us. Actually, if you look at our posters, this is actually my topic. I think end-of-life care for older adults bootcamp was the old topic that was for the in-person conference for 2020. And because in the past a year and a half, we've been in this COVID-19 pandemic, and it has a huge impact on end-of-life care for older adults. So I want to give you more relevant information. So I have no financial disclosure, but I do want to acknowledge that the foundation of the content of this talk is based on end-of-life nursing education consortium. And I also want to acknowledge the John A. Hartford Foundation. Many years ago, they actually sponsored my doctoral education by the means of building academic geriatric nursing capacity grant. And that grant allowed me to pursue my passion in gerontology nursing and also in palliative care. So I'm forever grateful to them. Okay, so today we're going to talk about how to take care of patients at the end of life, especially older patients, and what are the impacts of COVID-19 on providing quality care. So I'm going to briefly talk about aging and aging-related change and the older adults' unique needs. And then I'm going to focus on the impact of COVID-19 on that makes the providing quality end-of-life care challenge. And then I'm going to talk about ageism and discuss with you on why we need to care about ageism and how ageism created a lot of ethical issues during COVID-19 pandemic for older patients and end-of-life care. And next, I'm going to identify key strategies in providing quality end-of-life care for older adults. And at the end, I'm going to talk about opportunities that we can improve our quality of care for this very vulnerable population in the future. So let's start talking about aging and age-related changes in health. First of all, I want to emphasize age-related changes is different than illness or disease. These are natural occurring process. As people are getting older, our cellular and physical function is start to deteriorating, and that causes some system changes and the sensory changes, and that's what we call the age-related change. And this process occurs at a very different rate for different people. They become accelerated and more pronounced as people getting older and older, especially in older adults that's 85 years old or older. And these changes, they, although not diseases, but they can increase people's vulnerability to have disease or even multiple disease. And they also make people having a harder time to adapt to stress and response to stress. And that makes bouncing back even harder. And also because of these changes, often have a very atypical presentation when they have a disease, and that makes timely diagnosis of disease more difficult. And some of these common changes are, as you know, when people are getting older, their eyesight is getting worse and their hearing are getting worse. Their tasting ability is also getting worse. So all these sensory changes makes communication a little bit hard and making maintain good nutrition a little bit hard. And cardiovascular wise, when you're getting old, your cardiac output decreases, and pulmonary wise, when you're getting old, your lung capacity diminish, and your ability to eliminate secretions is also getting less effective. And that's why patients, older patients will have a harder time to bounce back from a simple cold. And oftentimes they're more prone to having pulmonary infections and pneumonia. Digestion wise, everything slows down a little bit. They may have constipation problems, and their absorption of nutrition also diminish. Renal wise, this age-related change cause the muscle tone sometimes lose, so they could have incontinent problem. And also their ability to eliminate waste also decreases. So older adults will have a higher risk of having a renal insufficiency. And the skin is the same. They're having higher percentage of fat. I'm sorry, they will have a higher fat tissue in their body, and they will have lower muscle mass, and their skin is not as supple as when people are younger, and they're more prone to have pressure injuries. So there are a lot of these changes. I'm just briefly overview some of them. And another thing I want to really emphasize is, as people aging and going toward the end of life, the mortality rate increases, and the older you get, the higher percentage of the older population is dying. So because all of these changes, older adults have a lot more comprehensive care needs. First of all, like everybody, they have basic needs. And because oftentimes older adults are retired, or as they're aging, they're more fragile, and they are no longer working. So they are more vulnerable to having housing issues and safety issues, nutrition issues. And because older patients, they are, a lot of their families will move away from them, and they are no longer in the workforce, so their social connection decreases. And as they're getting older, their needs for caregiving really goes up. And so we not only have to meet these needs, we also have to think about as their function diminish, their ability to independent living is also diminished, and their neurological status may also change. We have more patients suffering from dementia or other cognitive issues. So as part of healthcare providers, one of our goal is to help them maintain their cognitive functions and to try to help them slow down the functional decline. And also, we already talked about all this change, even though they are not disease, but they do make older adults susceptible for having diseases. And oftentimes they will have multiple different diseases like diabetes, hypertension, heart failure, renal insufficiencies, and how to manage all these different diseases, how to coordinate with a different specialist to take care of these patients are a challenge. And also geriatric syndrome is something we need to consider. Geriatric syndrome is a symptom or a group of symptoms that is related to older age, and it's like a domino. So one thing falls and then the other will happen as a chain. Like if you are thinking about incontinent, if a patient have incontinent issues, they are more they're more have a higher risk of developing urinary tract infections, skin breakdowns, and when they are trying to make to the bathroom, they have an increased risk of fall. So how to manage those, and also how to manage age-related functional disability is what we need to consider. And because as you're aging, the risk of death increase. So we have to think about how to do advanced care planning and how to provide end-of-life care. These are the unique needs that older adults have. And on top of that, you have to think about older adults. Their care oftentimes goes across different healthcare settings. They could be reside at home. They could reside in long-term care facilities, assisted living, or skilled nursing facilities. And if they are sick, oftentimes they are going to be transitioned from one settings to another settings. So inpatient care may go into skilled nurse facilities and then transition to outpatient visits or home health care. So we need a lot of coordination between different healthcare facilities. So all of this uniqueness calls for a really person-centered care and interdisciplinary care team. And that is why palliative care, geriatric palliative care, fits so well for older adults' care needs. And I really do think palliative care could help adults, older adults, especially as they're getting older, to have a much better quality of care if they can be involved early. So let's talk about how COVID-19 changed everything in the last year and a half. So first of all, I think all of you know older adults have a much higher hospitalization and mortality rate when compared to younger people. If you look at the CDC data, although people older than 65 years old only comprise 17% of the entire population in United States, but they really make up 31% of all COVID infections, 45% of all hospitalizations, 53% of intensive care unit usage, and more than 80% of all deaths are occurred in this age group. And as they're getting older, their risk of hospitalization and death is increased dramatically. And COVID-19 also have impact in other, in all aspects of older adults' life. So financially, a lot of older adults, they're on fixed income, and they may supplement that fixed income by either doing some part-time job or renting out properties. And when COVID-19 hit, oftentimes they will lose source of this supplemental income. They won't be able to go out and easily finding safe work. And also because our rent moratorium, oftentimes older adults, they don't have that part of income. If they're renting to other people, that part of income could also diminish. And a lot of them, because the stock market also lose some of their retirement savings. Physically, because of the isolation and shelter in place, a lot of older patients cannot have their routine care on time. This care can be delayed if they have some elective procedures and surgeries. Those got delayed as well. And with all the delay of care, and sometimes it's interruption of care, like if they are home health care recipients, those people may have an interruption in their routine care they receive because the home health aides, some of them are quitting their jobs, and some of them are refused to coming in, or the agency suspend all the home visits because lack of personal protective equipment. So this care delay and the interruption can have an impact on older adults' health. Either their medication management could be compromised, or the necessary procedure get delayed, or necessary care is not really provided for them. And also because we focused on shelter in place and asking older adults to self-isolate. And if they are in long-term care facilities, oftentimes there is a forced isolation order. And the older adults really couldn't do their regular routine exercise and couldn't have people coming to visit them and help them to mobilize. So many of them are suffered from deconditioning, and they become more frail, and they become having higher risk of a fall. And also, if they had COVID-19 and they survived the disease, oftentimes they are left with long-term effects like decreased lung capacity, or they will be long-term on oxygen. And we also have people who suffered a long-term loss of taste and the smell, and all of this making them more vulnerable to developing even more diseases and more severe diseases. And emotionally, you probably all heard this from all the news outlets. A lot of the older adults, they suffered loneliness, and they suffered fear, anxiety, because the uncertain future, and also oftentimes they feel helpless and hopeless because their family could not come to visit. They couldn't see their grandkids. And all of this oftentimes will have a long-lasting effect on older adults. And many of them develop the long-term mental health issues like depression, like anxiety disorder, sleep disruption, worsening dementia, and delirium. This photo actually comes from Seattle Times, and this is one of the residents in the Life Center, Life Care Center at Kirkland, where the COVID-19 first hit. And she, as you can see, all by herself, and you can see the sign behind her, the green sign actually says no visitation. So she is by herself and trying to do some exercise and to keep herself healthy. And a lot of the older adults have the same experience. And I think all of us experienced some of it during the COVID-19. And if we feel like our mental health is impacted, just think about how big an impact it would be for these older adults. And socially, these older adults, because of isolation, oftentimes lose their social support network. And losing that supportive network makes them feel even more hopeless. And oftentimes, older adults will feel like they're a burden, and they would think there is nothing worth living for. So all of this combined together makes providing end-of-life care to older adults even more difficult. When they don't have enough financial means, some of the more expensive care they no longer can afford. And with increased frailty, that could increase and accelerate their dying process and give them more symptoms. And imagine the emotional impact and how bad it's going to make these older adults feel when they're already suffering physical symptoms. Now we have added psychological symptoms for them. And then also they have to do all of this all along. So this makes providing quality of end-of-life care in this population even more challenging. also their research actually showing these patients, when they get COVID-19, oftentimes the older adults, their atypical presentation makes fever very, very unlikely. And they often have a very, very minimum cough. Oftentimes, their first onset symptom is change in their level of consciousness and also increased delirium. And when they're in long-term care facilities or at home, those symptoms oftentimes are get overlooked, and they oftentimes didn't get diagnosed in time until they get more severe disease. At the same time, they are spreading the virus to other people's in their living situations. Okay, so I'm showing you these two pictures to tell you what big of an impact COVID-19 have for providing end-of-life care to this population. The picture on the left is what we normally do things. End of lifetime is when everybody come together. There will be a lot of touch and there will be everybody involved. See that happy, peaceful, and content look on this old man's face and compare it to the picture on the right. One patient oftentimes is forced to die alone, and the only people are with them are the nurses, and families can only be seen with electronic devices, if any. And these are the lucky patients. They actually have somebody saying goodbye through the device. They have the nurse be there with them. But if this is not in hospital settings, if this is in long-term care facilities, older patients oftentimes don't have somebody with them. They're really just dying alone. And that is not a good quality of decent dying we wanted for this population. Okay, so given all of this, I want to bring up the ageism issue and why it's important to acknowledge ageism during the time of COVID-19 and why it's so important for end-of-life care. I want you to take maybe 10 seconds just to imagine. When I say older adults, what pops into your head? Is older adults looking like this? Or older adults looking like something different, more healthier? If this is what you think older adult looks like, this is unconscious ageism. If I'm saying and you're thinking about Dr. Fauci, you're thinking about Tom Hanks, you're thinking about the 90-year-old aerobic instructor, you see how different those images is to these patients you're looking at. But this is how society oftentimes think about older adults. And because of that, what you often see is this really negative attitude toward older adults during the COVID pandemic. So at the beginning, this is also Life Care Center in Kirkland. In March, this is always seen on television, whether local or nationally. You'll see older patients, frail older patients being wheeled out of the Life Care Center. And because all the media is broadcasting this image, and it gives people a different impression of who older adults are. There are studies looking at the Twitter feeds or the feeds in other social medias, and they found at least a quarter of all the posts are really negative about older adults, and sometimes it's even hurtful. Like people are selling t-shirts that has boomer remover hashtag on them, and on Twitter there are thousands of threads related to boomer remover. And this notion of COVID-19 only affects older adults really makes this them versus us mentality even stronger in people. And they see, many people see older adults as sitting ducks. The high mortality rate is being seen as it's a normal outcome. And they also think younger, healthier people are invulnerable. And then when New York City have a surge, and Andrew Cuomo was on TV talking about the short of ventilators, and the people start to discuss how to allocate resources, and that really makes the situation even worse. We have a lot of deaths, thousands of older adults, in fact, who died is simply just counted and summarized. And sometimes in some countries, in some areas,
I can't hear you right now, and I think you're frozen. Oh,
is that okay?
yep, that's fine.
Okay. So it just what I'm seeing is a lot of the older adult deaths in some countries, in some regions, are not even counted as part of the COVID death statistics. And that really makes people feel like older deaths is not as significant as younger people's deaths. If you look at the media, you will find there are a lot of long stories about patients who died of COVID-19 and are younger. It seems like these people worth a life story versus the older adults. Their deaths oftentimes is silent, and it just makes it merely a statistic, not even that significant. And all of this actually making older adults have internalized ageism toward themselves. They feel like they are a burden. They also feel like there is really nothing to live for. And you hear people actually talking about older adults in Italy. They sacrifice themselves and giving the younger patients ventilators instead of having them themselves. And those stories making more older adults feeling even worse about themselves. And in fact, there is an increase in elderly suicide and increased information requirement for voluntary assistance. I hear a big noise. So if somebody could mute. But that is not true. Older adult, when you think about it, age expand for 4 different decades from 65-year-old to over 100 years old. And a lot of older adults, they're not only the source of generational knowledge and wisdom, they're also part of the workforce. We have older nurses who are still working at bedside. Dr. Fauci is an 80-year-old, and we really don't know what do we do without him during the first couple of months when Trump administration is really trying to ignore COVID-19. And we also have a lot of older adults who are volunteers, and they are also caregivers, not only to other older adults and oftentimes to their grandchildren. And this contribution allowed younger adults to go outside and be part of the workforce, especially those essential workers. If they don't have their grandparents and the school is out, that would really affect their ability to work. And also, older adults helps with our economy, and they helps our society in many different ways. We really cannot afford to think about older adults and the loss of older lives as not a big deal. Okay. And during COVID-19, I find 3 ethical issues are very significant and very relevant toward end-of-life older adult care. First of all is the distributive justice. Justice is basically talking about the fair allocation of resources. It means in an equal circumstance, there should be equitable distribution of available resources. And we all know, even in healthcare system, that is not true. When we're thinking about allocate PPE resources, nursing homes and home health care often draw the short straw. They are the last in line to get the resources, but inpatient hospital care are where we really getting the resources. And in the hospital, even in the ICU, at the early stage of a pandemic, there is a short of personal protective equipment. And just think about how much worse it is in the nursing homes or at the home care agencies. And also thinking about the fairness, I want to bring up this ventilator issue again. And I can tell you, even at the highest of a surge, we talked about potential ventilator shortage, but they were never actual ventilator shortage. But they are a strong voice talking about we should allocate ventilators based on patient's age alone. And the older you are, the less chance you are going to get a ventilator. So this strong voice is so significant. It caused many aging agencies, the agencies who works and advocate for older adults, publish strong guidelines and the statement condemn using age as the single factor to distribute the resource. So that's the first ethical issues brought up by COVID-19. The second issue, more silently, is this using ethical principle beneficence, meaning doing the best good, thinking about the best interest versus autonomy and self-determination. What happened in a lot of long-term care settings is we have healthcare providers do a paternalistic treatment decisions unilaterally. They often decide on which patient can stay and be treated on-site and who to send out to the hospitals. And oftentimes the older patients are the ones who are determined not worthy sending to the hospital. And in the hospitals, it's the same thing. Oftentimes, when people deciding on whether to intubate a patient or not, age comes into play, especially the fragile older patients. There's often a tendency from the healthcare providers to say, we should not intubate these patients. ECMO is another good example. ECMO is basically the last resort for patient survival, and we don't accept the patient older than 60 years old. So all older adults, regardless of their health status, comorbidity, they do not get ECMO. And I would say if that is the patient's decision, or if it's an informed decision, that would be fine. But oftentimes, these decisions are made without the patient's input. We're really robbing the patient's autonomy. And even when patients, older patients, sometimes express willingness or wish to get more aggressive treatment, they oftentimes get denied based on their frailty. So that's another ethical issue that brought up. Is that a good decision or wrong decision? It's really hard to say. It depends on the situation. It depends on the case. And I would say if you have a healthy 65-year-old, otherwise no comorbidity, exercise regularly, in good shape, versus a 45-year-old probably have lots of comorbid disease. These two patients who have a better chance of survival, I would say maybe the 65-year-old. However, this is a conversation to have when it comes to treatment decisions. Another ethical issue brought up by COVID-19 is this notion of we isolate you because we want to protect you. We have done this from the very beginning of COVID-19, and a lot of facilities are still doing this. Some of the long-term care facilities, because of their lack of PPE equipment, and they oftentimes do it to an extreme. Older adults not only are not allowed to have visitation, they're not allowed to coming out of their rooms. And now the ethical issue is whether that is a human right violation. The older adults never in these isolation decisions. And as a human being, they have the right to maintain their social connectedness, especially when social connectedness in older adults oftentimes is a determinant factor for their well-being. In nursing homes, when there is a short staff, when there is a short of resource, sometimes the family are the ones providing the care for older adults and help fill the gap. And when there are not a lot to coming in, the care quality for these older adults are really diminished, especially when the older adults could not advocate for themselves. Those patients who are disabled, who have dementia, oftentimes they are suffering and quickly die during the COVID-19, not because of COVID-19, just because they're in isolation. So which one is more important than the other? We really have to think about this as healthcare providers. Should we isolate patients to protect the crowd? Or is there any way we can allow visitations safely and keep the patient's human rights intact? Okay, so all of these ethical issues have a huge impact on the quality of end-of-life care, as you can see. And so how do we provide high quality of end-of-life during pandemic? First of all, yes, we do want to follow infection prevention guidelines, but maybe we can make exceptions, especially when the patient is actively dying. Can we allow visitors to come in, even just one of them or two of them, so they can see their final goodbye in person, not via an iPad? We need to balance these two during a pandemic situation. And also, as healthcare providers, we have to start to embrace telemedicine. Doing telemedicine, even though it's not ideal, but it does allow us to minimize disruption of care and the service older adults really needed. And we want to do teleconference instead of just a telephone call when it's possible. There are study data that showed when people are able to see your face, they are more engaged and they feel they are more involved in their own care, and they feel like their needs are being heard better than they just talk to you on the telephone. So we need to really start to utilize more telemedicine to check on people, not only on the patient, but also on their family members. And telemedicine also allowed us to talk about things like treatment decisions, advanced care planning early on. And also, we need to use evidence-based end-of-life practice. I'm going to share with you a few symptom management practice that is evidence, that is supported by evidence. But we need to have standard guidelines, follow those guidelines, and providing end-of-life care, even with limited resources and limited access to patients. We also need to manage patients' psychological or mental health issues and incorporate manage their mental health issues as part of their end-of-life care. We can differentiate what is really demoralization, what is true depression, and if it's demoralization, how can we help the adult to see meaning in their life? And if it's depression, how we can treat depression using non-pharmacological and pharmacological means. If we have dementia patients and without their family who are familiar to them, and if at the end of life they're agitated and cannot be counseled, then maybe we can utilize a palliative sedation as an option to diminish their sufferings. And then it's very important, we need to provide respite and support to each other. We've been at this thing for 1.5 years now. And even if your job is in palliative care, hospice care, even if you're dealing with death in and day out, this past 1.5 years, we have so many deaths occurring, and it's relentless. There is no break. If we don't really talk with each other, support each other, and maybe take a break to take care of ourselves, we cannot continue to provide the highest quality of end-of-life care to these patients. So very, very important, we do all of this. And I want to spend a little bit time talking about some of the common symptoms we see in end of life, especially in end of life patients who has COVID-19. The first symptom I want to talk about is delirium. As I talked earlier, delirium, often for older adults, is their onset symptom for COVID-19. And this delirium oftentimes are increased in intensity as the patients at the end of their life in COVID-19 patients. The best strategy to treat delirium is to evaluate what risk besides COVID-19 we have, and to try to prevent and to eliminate all the risk factors that could cause delirium that's not associated with COVID-19. Things like maintain a regular sleep schedule, help older adults to exercise as much as they can, even when they're at the end of life, still do some movement. It will help with sleeping. And we also want to eliminate other possible diseases that could cause delirium, like UTI. And if they are hypoxic, we can using oxygen to treat hypoxia so they don't contribute to delirium. So things like that, think about eliminate other risk factors. And if the delirium really is caused by COVID-19, then the only thing work for them is to using antipsychotic medications to treat their symptoms. And in some more severe cases, like patients who has dementia and now have agitative delirium, we may have to think about using palliative sedation if that decision is made with the healthcare providers and the patient family. We want to eliminate the use of benzodiazepines if all possible, because oftentimes in older patients, benzos can worsen delirium symptoms. And our non-pharmacological treatment should not be diminished, even in COVID patients. We can make sure patients have a calm environment, decrease stimulation. We're not going to arguing with the patient who are agitated. We're going to gently reorient them often, every chance we get. And we want to assure them that they are safe. And we want to make sure that if they are hard of hearing, if they are having eyesight issues, we have the equipment, the devices that can correct those impairments with them at all time. And very, very importantly, in the end-of-life patients who are delirious, we want to try everything to avoid the use of restraints. We should not use restraints on these patients unless there is just absolutely no other ways. Restraint causes suffering, even though it could keep them safe at times, but at the end of life, comfort is much more important. So that outweighs the risk of safety to a certain point. So we want to really make sure we eliminate the use of restraint. Okay. So the next thing I want to talk about is depression. Surprisingly, and not surprisingly, is increased in is really we have an increased rate of depression in patients who has COVID-19 and at the end of life. And These depression oftentimes are related to social isolation and all the other things we talked earlier, and also the internal ageism can play a part to their depressed stage as well. And for depression, we want to maximize all the non-pharmacological strategies we can have. We want to give them some control back. We want them to have a voice when it's all possible, listen to what they want and try to give them what they want. And we can talk to them if we have the means of even remote device. We can talk about their lives together and try to help them find hope, try to help them find meaning of life. And if we sense or observe the internal ageism, we can talk to them and trying to reverse some of this negative impact to them. And we can do grief counseling and talk about their loss and talk about potential legacies they can leave. And we can also do cognitive behavioral therapy. If none of them works, or if the patient is severely depressed, we want to combine the non-pharmacologic treatment with some medications. We do have antidepressant that we can prescribe for older patients at the end of life. But the caution is these medications oftentimes take a long time to take effect, and it may not be act quick enough, especially with COVID-19. A lot of these patients die pretty quickly. So focusing on non-pharmacological interventions. One last thing I want to talk about depression is increased risk of suicide ideation and suicide attempt in older population who has COVID-19. We have seen an increased suicide rate in older patients during the last year and a half. And to combine to really combat this suicide ideation and the suicide attempt, we need to emphasize on safety assessment, really talk to them, ask the question, ask, do you have ever thought of hurt yourself? And do you have plans? Really ask those questions and intervene as soon as we identify the issues. And again, non-pharmacological interventions has a huge impact in controlling depression, but also consider antidepressant or other medications to treat patients who are having a depression. Okay. The most common symptoms in COVID patients who are at end of life are dyspnea, and it is true for older adults as well. And we find in this population, the good news is all the traditional interventions works for COVID patients as well. Even though they suffer more severe dyspnea, but they can often be very well managed by giving oxygen and also moderate amount of opioids medication. Bronchodilators and the steroids medication also help treating the dyspnea. But again, non-pharmacological interventions should also be used. We can prevent a fan, and the fan usually work really well when the patients have a severe dyspnea, to really getting rid of that air hanger for them. And positioning is also helping. These patients often can benefit from just sitting up. And also just providing a calm environment and really treating their anxiety oftentimes will do wonders for dyspnea in this population. Okay.
Hi, I'm gonna interrupt really quickly. We are out of time.
Okay.
I
Yeah,
think this is your last slide, but
yeah, this
you are
is-
welcome to stay. I just want to be aware of our.
Okay, yeah.
Yeah.
And yeah, so we do have some future opportunities. One thing want to really, because end of life older adults care is across different healthcare settings. So in the future, we want to probably strengthen our collaboration. And also now we're using telemedicine. We may want to continue using that technology to have more frequent contact with our patient. Proactive care planning is something that has been brought up over and over during this COVID pandemic. And to use remote technology so we can reach families who are otherwise not available, so we can talk about care planning early before a crisis is very important in the future. And then another thing is we need to consider how we can support the people who provide end-of-life care for older adults during pandemic period, and the family members who has people died during this period with spiritual and psychosocial support in the future. So these are the things we also can think about. Okay, so that's all my slides. I just want to, at the end, emphasize the importance of nurses and our role in providing quality of care at the end of life for this vulnerable population. This is nurses. They take care of the patient physically, providing all the treatment the patients need. These are nurses. This is a traveler nurse in Evergreen at the beginning of the pandemic. This is the patient, is the husband who is dying of COVID-19 and ready to be withdrawn. And then this is the wife outside, and the nurse making the connection between the husband and the wife and allow them to say goodbye. And this is also nurses. These are Brazilian nurses. They have a severe short of staff and so many patients. And when the nurses have to take care of 20, 30, 40 patients, they don't have time to provide the quality wanted. So they are innovative and they make God hands. Fill the gloves with warm water so the patients don't feel like they're alone. They can feel like somebody is holding them as they're dying. These are nurses. We are innovative. We are passionate about providing care to these patients. And I'm sure if we put our heads together, we are able to solve some of the challenges facing us, even in a pandemic. So that's my presentation. And thank you again.
Thank you for that excellent talkie. I'm going to drop the course evaluation in the chat box. If you think of any questions in the near future, feel free to email them to palcenter@uw.edu, and I can pass your questions along. Let me just drop that link. Hold on. All right. And for those of you who are UW Medicine employees, I do encourage you to check out capc.org for free resources. I will follow up with an email with a link to the recording and all of this information. Thank you so much for joining us, and we will perhaps see you next Friday.
Thank you.
Have a good one, everybody.